Hi, this is Danica, and I will be talking about the acute renal failure case study. So our case, one of the first patients of this morning is a 67-year-old male with past medical history of hypertension, obesity, diabetes type 2, and prostate cancer. Presents to your office with a 2-day history of fever, shaking chills, right lower quadrant abdominal pain, nausea, and vomiting. Within a short time of evaluating this patient, you acknowledge he will need an additional inpatient treatment. You're working in a rural clinic attached to a critical access hospital with admitting privileges. You consult your attending MD, and he advises you to proceed with admission orders and follow-up. He will round with you after clinic. In the review of systems, there is notable for chronic urinary frequency, denies any chest pain, shortness of breath, changes in bowel movement, dysuria, rashes, joint pain, or focal neural symptoms. He does not smoke or use alcohol, and the review of systems is otherwise negative. So his past medical history, his diabetes is well controlled with an A1C of 7. He has no known retinopathy, neuropathy, or nephropathy. Hypertension is well controlled. He's obese with a BMI of 34. His lipids are well controlled with an LDL of 89. And he has had prostate cancer that was diagnosed in 2000. So he had radiation and chemo. He's had a stable PSA since, and that was last 2 years ago. Medications include metformin, Lipitor, glyburide, enalapril, and hydrochlorothiazide. Upon initial physical examination, his vital signs: temp of 102, heart rate 111, respiratory rate 18, blood pressure 142/62, oxygen 97 on room air, and weight of 220. He is ill-appearing and diaphoretic, has no respiratory distress. He's tacky, and he has poor dentition. He has tachycardia. Rhythm is regular with no murmurs, flat neck veins. Abdominal is normal. Soft, right lower quadrant pain, tenderness, but no rebound or guarding. His guaiac is negative, no apparent prostate nodules, enlargement, or tenderness. Extremities are warm, there's no rashes, no edema. Pulses are 2+ bilaterally. For his notable labs, his white blood cell count was 22, with 80% of neutrophils, 22% leukocytes, and 5% basophils. His BON is 55, creatinine of 2.6, sodium 142, glucose 222, and bicarb of 20. In his UA, his specific gravity was 1.025. Positive for nitrates, 1 to 4 red blood cells, 10 to 20 white blood cells, 3+ for bacteria. There were no casts and no protein. His liver function test, chest x-ray, and EKG were unremarkable. So the first question: what are 3 admitting diagnoses for this patient? The 3 admitting diagnoses for this patient that I would think of would include acute renal failure, possible sepsis or a UTI, or appendicitis based on his presenting symptoms. There are 3 main categories and causes of acute renal failure. What are they? So the 3 main categories include pre-renal, intrarenal, and post-renal, which are based on BUN and creatinine ratio. Pre-renal failure is the most common type of acute renal failure, and this is caused by intravascular volume depletion, which results in renal hypoperfusion. Intrarenal failure is classified as tubular, glomerular, interstitial, and vascular. Finally, post-renal failure is caused by a physical obstruction of urine outflow, which could be caused by a neoplasm, prostatic enlargement, bladder dysfunction, strictures, or nephrolithiasis. Which type of renal failure does this patient appear to have at this time? Based on his presenting symptoms and his lab results, I'd say that he has a pre-renal acute renal failure, and that's due to a variety of factors. So first, the patient's urinalysis exhibits no casts, which is a normal finding with pre-renal failure. whereas the presence of CASK suggests an intrinsic cause. Second, the patient is prescribed enalapril, which is an angiotensin-converting enzyme inhibitor, which can impair renal perfusion by dilating the efferent arterioles and reducing the intraglomerular pressure. Other labs that point to acute renal failure include slightly elevated potassium and decreased bicarbonate level. Another finding supportive of this is the ratio of BUN to creatinine, which is shown below here. So BUN to creatinine ratio is the blood urea nitrogen divided by serum creatinine, in which this case was 21.2 to 1, which supports the proposed type of acute renal failure, as the average pre-renal cause has a BUN to creatinine ratio of above 20. Question 6. The fractional excretion of sodium, or FeNA, is another useful calculation to help determine the cause of acute renal failure. What additional labs will you need to order to calculate this ratio? And what medications might make this calculation less useful? So the FeNA is calculated as urine sodium times plasma creatinine divided by plasma sodium times serum creatinine times 100. So the FeNA is the fraction of sodium that's actually excreted relative to the amount that's filtered by the kidney. In order to calculate the FeNA, other labs that would need to be obtained include a urine sodium and urine creatinine, as they have already provided a serum sodium and a serum creatinine. Medications that might cause an increase include antibiotics, cough medications, laxative, and steroids. Drugs that may cause decreased levels include diuretics and steroids. So when admitting this patient, you need to write admission fluids. So the fluids that I would order include an isotonic solution such as normal saline or lactated ringers. And these initial fluids should run at 1 ml per kilo per hour, which in this case, if rounded up, would be 100 mils per hour. So the nursing orders that will help me to monitor this patient include fluid and electrolyte status, specifically looking from a shift from oliguric phase to a diuretic phase, which can cause hypovolemia and electrolyte loss. Daily weights will help to trend the amount of fluid retention that's occurring, as well as strict intake and output status, in which a urethral catheter should be placed. So what medications from his chronic list will you continue? Although ACE inhibitors have been shown to decrease renal function, I would still continue to use the ACE inhibitor until the serum creatinine level rises to more than 30%, or if the potassium level rises to 5.6 or higher. Recommendations include 75 to 100% of normal dosing of enalapril. I would also continue the use of Lipitor and hydrochlorothiazide unless the creatinine clearance decreases to less than 30 mils per minute. At that time, I would utilize it in combination with a loop diuretic. So new medications that I would add include an antibiotic due to his white count elevation and bacteria within the urine. So since he's going to be admitted to the hospital, IV antibiotics can be initiated rather than oral. And the primary options for IV antibiotics would include levofloxacin, 500 milligrams IV once daily, and ciprofloxacin, 400 milligrams IV every 12 hours. So because this patient is clearly having renal problems, his medications may require additional renal dosing. So in order to accurately calculate the creatinine clearance, I would need a 24-hour urine sample, but the estimated creatinine clearance using the Cockcroft-Gault equation is 38.91 mils per minute, with an estimated GFR of 26.3 mils per minute. Since there's no current dosages for the patient's medications, I would adjust them as follows. So the enalapril, I would do 75 to 100% of usual dosage. His metformin, I would discontinue this medication for the time being, as 90 to 100% of this medication is renally excreted, and it's not recommended when the serum creatinine level is higher than 1.5, in which this case it is. His Lipitor, no adjustment would be needed. Glyburide, this medication would also be discontinued, as it's not recommended in patients with a GFR of less than 60. Hydrochlorothiazide, no adjustment is needed until the creatinine clearance is less than 30. So, in the scenario, while you're busy thinking through these issues and writing your orders, the admitting nurse comes to say that this patient's blood pressure has dropped to 80/40, which has been double-checked manually. His pulse is now 130, and he has not had any urine output since coming from the clinic. So my first order, due to his dramatic drop in blood pressure and increase in heart rate, I would think that he's hypovolemic. So I would order a 500 to 1,000 ml normal saline bolus. So this med student that has been following asks if now would be a good time to start dopamine because he has heard that this has increased renal perfusion. What would I tell him? So in recent studies, there has been no clinical benefit found with the use of dopamine in patients with acute renal failure. The thought behind the use of dopamine is to increase renal blood flow and stop or slow the progression to intrinsic renal failure. However, it's been shown to have many potential side effects, which include tachycardia, arrhythmias, myocardial ischemia, intestinal ischemia, and postoperative atrial fibrillation. So I would not start dopamine at this point. So the patient is admitted with fluids and medications that I've ordered. By hospital day 2, tachycardia, fever, and hypotension have resolved. BUN and creatinine have improved to 35 and 1.9. The patient's abdominal pain persists, and an abdominal CT is ordered. Name 3 things that you might consider to help prevent worsening renal failure from contrast dye administration. So because he's showing signs of acute kidney injury, the prevention of any further damage by contrast dyes should be taken into consideration. It would be recommended that no contrast dyes be used for this patient. However, if IV contrast is going to be used, the patient should have volume expansion therapy in order to reduce the incidence of contrast-induced nephropathy. Another general measure that can be taken to decrease the risk of renal damage includes using a lower dose of contrast, and those that are either non-ionic and that have low osmolalities, typically about 500 to 850 osmolalities per kilo. So the orders written regarding the abdominal CT renal precautions were unfortunately missed by the unit secretary. The CT was performed with IV contrast, but the PAX is broken and no results or images are available. What are your thoughts or concerns? So the concern in this case would be the development of contrast-induced nephropathy, which can lead to acute kidney injury, which is generally reversible. However, in his case, the patient's kidneys are already compromised. Typically in patients with contrast-induced nephropathy, creatinine will increase within minutes of exposure to the contrast agents, and he'll have clinical manifestations of oliguria presenting within 24 to 48 hours after exposure. So in the evening of hospital day 2, you're called because the patient has had no urine output this shift and has had increased abdominal discomfort. What can you ask the nurse to do while you're on your way to see this patient? At this point, I would ask the nurse to do a bladder scan to see the amount of urine that's in the bladder, and then I would have them place a urinary catheter to drain it if there is. Otherwise, any other comfort measures that may be helpful for the patient. So as you walk down the stairs, what are the differential diagnoses you are generating in your head for oliguria, anuria in this patient? So my pre-renal differential diagnoses could be a decreased volume, hemorrhage, or sepsis. We've given him quite a bit of volume now, and there still could possibly be a hemorrhage, and he did come in with an elevated white count and temperature, so sepsis would still be on the table. Post-renal differential diagnoses. So the one I'm thinking about now is a urinary obstruction. That could be caused from a urinary stone, prostatic hypertrophy, or malignancy. Upon exam earlier, he didn't have any prostatic enlargement, so the thoughts of a urinary stone or malignancy would be options. Intrarenal differential diagnoses. He could have the contrast-induced nephropathy because he did get the contrast dye at his CT, or glomerular nephritis. So you come to see the patient. He appears uncomfortable. His recent vitals are a temp of 99, heart rate of 103, blood pressure of 100/80, respiratory of 18, oxygen of 98 on room air. Exam is notable for mild abdominal distension, normal blood sugar, no guarding or rebound, diffuse and non-localized abdominal tenderness. CVA tenderness is present but less prominent than on previous exam. Foley is with 100 cc's of dark brown urine in the bag. Its last was emptied about 7 hours ago. Patient's only medications at this time are the antibiotics and fluids you ordered on admit. What 2 interventions could be done immediately on the floor to help decide if there's a post-renal cause of oliguria? A renal ultrasound can be done at the bedside in order to diagnose a urinary tract obstruction, and this test has a sensitivity and specificity of 90 to 95%. Again, another bladder scan can also be done to assess the size of the bladder to see if there's even being any urine made and tell us whether or not a post-renal obstruction is likely. What lab studies would you like to order at this time to try and distinguish renal from pre-renal causes? So I have a chart within my paper here that kind of shows some of the common lab values that could possibly be ordered and shows the values of either pre-renal or renal. Have you guys looked through that? So assuming your tests from previous questions are unremarkable, and while you're waiting for your lab results to return, which of the following interventions would be most reasonable next step? So the main treatment of oliguria is identification and correction of the renal insufficiency. We should provide him with supportive measures such as avoidance of nephrotoxic agents and optimize renal perfusion through the correction of hypotension. I would also want to prevent and correct any hyperkalemia or acidosis that may present. So the patient's lab values, his specific gravity is 1.02, red blood cells 1 to 4, white blood cells 10 to 20, protein 1 plus, urine creatinine of 45, urine sodium 22, serum sodium 147, potassium 5.5, chloride 113, bicarb 22, BUN 66, creatinine 3.6, and glucose of 189. The patient has not had any additional urine output with this therapy. So when calculating the fractional excretion of sodium and BUN to creatinine ratio, it would be the urine sodium times serum creatinine divided by serum sodium times urine creatinine times 100. So that comes out to be 1.197. And if the cause of the azotemia is pre-renal, the FeNA would result in less than 1%, whereas if the FeNA was above 1%, it could indicate acute tubular necrosis, which could be present in this patient, or it could be a post-renal cause at this point. Keeping in mind the 3 categories of acute renal failure, what's your differential diagnosis of anuria now? Please use lab interpretation and clinical history to support this. So since there's been little success or findings at the diagnostic test that we've done, I would suggest that this is most likely a post-renal cause, possibly from an enlarged prostate due to his history that he's had. But it could also be due to a kidney stone that's trying to pass. The acute renal failure could also still be caused by a pre-renal issue such as kidney infection, but it's becoming less likely. So the attending suggests a renal ultrasound, and these results return in the morning along with the CT. Both are demonstrating right-sided hydronephrosis and ureteral dilation. So a urologist is consulted and is scheduled to be at the facility for outreach clinic in the AM. Over the next 24 hours with supportive care only, the urinary output increases notably and creatinine stabilizes at 2.6. So can you explain this clinical presentation? So according to the National Kidney Foundation, the presence of hydronephrosis on renal ultrasound suggests swelling of the kidneys due to a buildup of urine that's possibly caused by an obstruction or a blockage of some sort. So causes of hydronephrosis can include a kidney stone, blood clot, scar tissue, prostate tumor, enlarged prostate, and urinary tract infection. With the spontaneous return of urinary output, the patient could have passed a stone if that was what was going on, or it could also be due to infection, which has cleared with antibiotics that I originally started. The patient is, since this episode, he is at increased risk of chronic kidney injury due to a variety of factors, such as his history of diabetes, history of AKI, oliguria, drugs with nephrotoxic potential, and a history of urological obstruction. So you'll see some of the questions here that I have for the group. Please let me know if you have any questions or any suggestions. This one was a tough one for me, so hopefully we can figure it out as a class.